Hi, everyone. Don't want to keep you too much longer because you probably all stomachs are growling. I want to thank, first of all, the different researchers that were up here today because that was 12 of many people that are contributing to the research base that we have in Nemaline and other rare diseases. I just want to say, like what I mentioned yesterday in the group meeting with the scientists, was 10 years ago, 11 years ago, when I first joined this cause, there was a really interesting, it was really interesting for me to hear the language that was being used in the scientific meetings, that they were primarily worried about diagnosis and improving diagnostic capabilities and diagnostics earlier in the process so that people weren't painstakingly hearing about all these horrible things that your child could have. And now that we've actually improved the pathways towards diagnosis, there's been a lot more depth of understanding about what the different mechanisms of these different gene causes are having the impact on the physiology of the muscle. And what I was hearing yesterday in the scientific meetings was a way different language. It was way more translational. And that means, again, we're trying to think about how we can take the science and actually impact the person with the disease. So that was really important for me to hear. It was also really important for me to hear the positive outcomes that some of these fellows right here are coming up with. And I think we heard about some existing medicines that could help sooner than later, which is really great. But we're also hearing about money being poured into genetic modification and improvements. So that to me was really beneficial. So I think I'm going to lean on Alan to talk a little bit more about where he hopes the next steps are for the treatment of Nemaline and how we as a community can help improve their mechanisms for support.
All right, thank you, Marc. So you can break it down into a couple of different areas, and one of them in general we call clinical trial readiness, which is kind of jargon in the drug development community. As an academic, I'm starting to get exposed to a little bit of this. And then there's obviously the basic science that leads to the proof of concept and the preclinical studies that actually develop a scientific or a medical method to treat something. So let me talk first about clinical trial readiness. And I think that that's something that you guys have supported tremendously over the years. Many of you have enrolled with my laboratory. Many of you have been involved with some of the investigators in Australia and in Europe. And we, as investigators, have had a very good, pretty tight-knit community. We have conferences every few years, usually in Amsterdam, of 20 to 23 or 4 investigators representing geographically and scientifically the different areas that are involved in all of this. And it's been, from our perspective, a very collaborative environment. Investigators from Asia and so on. And in terms of clinical trial readiness, what we need to know is there's a few key things. We need to know who the patients are, who has the need. In the case of Nemaline myopathy, because there are a variety of different genes that can all cause it, we need to understand which genes everybody has, and that, Marc, in the very beginning we were struggling with that. We were still trying to find the genes. There probably still are 1 or 2 out there, maybe a few more that we haven't discovered, but we feel like we know about most of them. We need to then understand what's called the natural history, essentially how do people develop and grow and live their lives when they have these conditions, and can we make predictions? And making predictions, it's useful and important to you as families to know what to expect, but it's also critical if we're going to test any particular drug or treatment, because we don't have, with heart disease or cancer, you can enroll 5,000 people and you can say, we're going to give 2,500 of them a drug and the other 2,500 we're going to give a placebo, and we're going to compare the groups. But that's not possible with a rare disease. So we need to be able to predict and know what to expect so that if we give a treatment, we can evaluate whether that treatment is really having a benefit. So along those terms, we have registries. A registry is simply just knowing who people are, having contact information, permission from you guys for us to contact you and ask follow-up questions, to let you know if there's something relevant that's happening. The natural history I mentioned, obviously, that involves collecting medical records. Sometimes it involves coming into your doctor and having some tests done, in particular measuring pulmonary function or muscle strength and so on that I'm sure Dr. Servet probably discussed earlier. And so that's clinical trial readiness.
Yeah, so clinical trial readiness means that they can actually take the patient and actually apply an experiment, right, and be able to measure the effectiveness, right? And that's something we haven't done in Nemaline just yet. It's something we're trying to get to a point. My phone is ringing. I don't know. Sorry. It's probably one of my kids. Anyway, so I think the steps that we've taken as an organization, AFBS, but also with the different researchers around, has been to try and support the registries, try and support the tissue repository, try and support the animal model development. And that's something that is continuing, and we've seen like a lot of positive progress. Zebrafish didn't exist 10 years ago. We were in very many discussions about them, and now all of a sudden we're seeing we can actually make manipulations to actually reproduce your exact gene presentation in that fish, and then also then go through the exercise that we need to make sure that it actually does match up. And then we can actually run through experiments. And just to give Dr. Bryson Richardson kudos, I mean, he has tested over 100,000 fish with Nemaline in these different drugs, am I right? So that's a crazy amount of interventions and being able to measure that. My phone's ringing again. My daughter. Anyway, so sorry, I got thrown off. So anyway, so that's what our organization has been doing, and I think we've just finishing up kind of the second year of our last request for proposals. And so a lot of the people who are presenting today have been funded by AFBS. We've now committed $600,000 over the next 3 to 4 years to actually support the natural history study. We're also applying to the NIH and the MDA for support as well. And so that will give us momentum. And then we're going to hopefully partner with the European contingent, which Laurent is going to run. That includes starting off with a kickoff meeting in September that will help coordinate the US efforts and the European efforts, hopefully as well as Australian and even the Asia. So that is a big step. And that'll hopefully put us in position so that when we do find something that is a small molecule that might be able to intervene with all of us, universally, or independently with those that might be, interacting with a specific drug, then we'll be able to move forward. So that's, I think, where we are with what's next. We also talked about in the meeting yesterday how because we have some money in the bank right now, we're actually going to open up for a new series of projects starting this October. So we're actually going to be accepting applications for new project work. And so hopefully we'll actually invite even more scientists into the fold. And I think Dr. Gupta mentioned yesterday, it's time to actually try and invite maybe someone who's had success in the field of genetic modification into the world of NM, because maybe we don't have someone in that area that's really strong to make that approach. Is that right? Did I summarize? Okay. Does anyone have any questions that they want to ask? Nothing too silly. Silly for me, maybe.
Right, yeah. I guess my question, and I don't know if it's going to come out really well, but there's like a bunch of NEB stuff, and then there's ACTA stuff, and it seems like those worlds are like very different. So is there a point that like that breaks apart, and you have more of like the ACTA and Nemaline group that's separate than NEB? I don't know if that's...
Yeah, I would know.
Because it seems like it's very different. Okay.
They are very different in terms of the biological aspects and challenges. So one gene is big, the other is small. So the challenges are different. There are groups that focus preferentially on one or another. So for example, the Helsinki group discovered the nebulin gene, and they're the leading expert. The group in Perth, Australia, and to some extent in Melbourne, is focused a little bit more on actin. But you've worked on nebulin as well. I'm pointing to Dr. Bryson Richardson. And my lab has studied both. And Asla Dr. Eikenot has been working on troponin T1, and Matthias Lambert has been working on tropomyosin 2 and tropomyosin 3. So we're trying to keep a unified approach here, but when we talk about what may work for one or another of these genes, it's a very different answer potentially. So that's why it may sound a little bit different, but you guys are all faced with the similar challenges, and we're all trying to apply similar tools to address those challenges.
Special thanks to Alan for, God, I can't do this, for all his help over the years. You've been really helpful.
That's the second time I've seen him break down over the last 3 days.
I'm invested, I'm sorry.
I couldn't give him a hug last time he was at the front of the room.
All right, so there's plenty more sessions to go. Stay involved, push with questions, pull people aside, read the posters as you get walking past them to understand more. But there's really been extraordinary work being done. I'm very proud of it. I'm very proud of these people. All right. Thank you, everybody. Go eat lunch.
Thank you.